Good afternoon. Oops, wait a minute. There.
Hello, Katie.
Hey, good afternoon. Good afternoon. Welcome to everybody that's here and also that's joining us online right now. I will call the meeting to order of the House Study Committee on Childhood Lead Exposure. This is our fourth meeting. It's been a very enlightening conversation. I think there will be some impactful outcomes that come forward from this. So I thank each of you for participating, our members, as well as all of you who have and will testify. We've got an interesting day today, so let's get right into it. Our first presenter will be joining us on Zoom, Dr. Robertson Howard, pediatrician at the Harbin Clinic Pediatrics in Rome. I will tell y'all that I did not pick her, but if I had, I would have. If I could have. She's a great pediatrician and takes care of so many issues in Rome, and is also very, I would say, very forward thinking in the things that we also need to work to diagnose early and prevent, which is a world that I try to operate in as well. So Dr. Howard, are you with us? You may want to tell everybody a little more about yourself too.
Good afternoon, and thank you so much for letting me come and speak. I am a native Georgian. I was born and raised in Augusta. I attended the University of Georgia for college and the Medical College of Georgia for medical school. I did my residency in Akron, Ohio, and returned back to Georgia and started to work in Rome probably almost 26 and a half years now. So my greatest accomplishment are my children and my grandchildren. So I'm going to get right to it. I'm going to say I reviewed the previous meetings, agendas, and slides. So I know you guys have already heard a lot about lead and the effects of environmental exposure. So what I'm going to try to do is give you a pediatrician's perspective as to why lead screening is so important. Elevated lead levels in children is kind of like elevated blood pressure in grown-ups. It's undetected until it's measured, but while it's going undetected, it can be silently causing damage. And like blood pressure, the longer it goes without treatment, the more damage it can cause. Because lead is a nerve poison. Even at levels as low as 5, it can cause damage to the nerve cells, which can result in neurocognitive deficiencies in children. It can also have a wide range of effects on the child's development and behavior. Children with elevated lead levels have been noted to have a decrease in their IQs, sometimes as much as 10 points. They are also at an increased risk of developing hyperactivity, inattentiveness, and irritability. This is why it is so very important to me as a pediatrician to be able to screen for elevated lead levels. Early identification and treatment of lead poisoning reduces the risk the child will suffer permanent damage. Risk assessments for lead are performed at all well child visits starting at 6 months of age. This is when the child begins to move and begins to do more hand-to-mouth activities. We continue the risk assessments through the age of 5. The risk assessments consist of questions designed to identify environmental exposure. We ask questions to know where the child spends time and if it is in constructions that were built prior to 1978. We know that prior to this time, lead was used in paints and pipes and even can be present in the soil around constructions. We do our first lead screening at 12 months of age. A lead screening is an actual blood test to detect lead in the body. For children who have insurance through Medicaid, we repeat the lead screening again at 24 months of age. This service, however, is not covered by most private insurances at 24 months. We can always do a lead screening anytime, regardless of age or insurance, if the risk assessment for lead is positive. So I wanted to share with you a story about a set of twins in our practice to kind of help you see how this works. The twins were seen at 12 months for their routine well visit. They had negative lead risk assessments and had blood lead screenings that showed lead levels of 2 and 1, which are normal. They were seen again at 24 months for a well visit. And again, the lead risk assessment was negative. But because the patients were on Medicaid, lead testing was mandated. The levels obtained at that time were found to be elevated. They were high at 23 and 11. We confirmed our lead screening, which is a finger stick, with venous blood draws, and the lead levels persisted in their elevation. Treatment for elevated lead levels began with obtaining a more detailed environmental health history to help identify the lead source, and if possible, remove the child from said source. Upon further investigation and with the help of our local health department and environmental services, we were able to identify that the parents had recently moved into a new rental property and that the property was known to have lead-based paint. The landlord had been unwilling to abate the lead, and moving out of the property was not an option for the family at this time. But again, with the help of our local health department and environmental services, parents have been instructed on ways to decrease the exposure risk for the twins. Their most recent lead levels were obtained, and although they're still elevated, they have decreased to 8 and 5. There are several barriers that we face when performing lead risk assessment and screening. One of those barriers is the risk assessment itself. This assessment is done, as I stated, at well child visits starting at 6 months. But we also assess at that time any risk for TB exposures, food insecurity, oral health, and sometimes maternal depression, anemia, or dyslipidemia. This can be overwhelming for a parent who is trying to answer questions while taking care of a child. Sometimes the answers may be inaccurate because the parents simply rush through them. Sometimes the answers are not accurate because the parents are unaware of their potential exposure and answer inappropriately in the negative. Sometimes the answers are negative because the parents do not want to risk having to lose or change their housing. A second barrier is the test itself. So in my office, the test is a send out and is run through a local laboratory. And these results are usually available within 24 to 48 hours. Some pediatricians have to send the patient to another facility to have the test drawn. And this can be an added burden for a parent. The ideal test would be a point of care test that could be done in the office with timely results. This way, if there are any issues or concerns, we could start addressing them before the patient even leaves the office. This kind of point of care testing has been available until recently when the CDC did a recall on the device. Offices that had been using this device is now having to go back to send outs. The third barrier is insurance coverage for the test. Currently, the test is covered for all children at 12 months of age and anyone with a positive response on a risk assessment. Private insurance does not cover the test at 24 months if the risk assessment is negative. This is a concern because sometimes, as I've already stated, negative responses are chosen inappropriately, and we may be missing children with elevated lead levels. The best treatment for elevated lead levels, of course, is prevention. And I recognize that this is a huge environmental problem and that the fix will take time and money. But I also realize there are lots of other challenges like food insecurity, education, and other determinants of social health that affect the neurocognitive growth and development of children and may take a priority over the issue of lead. But because it's important to identify elevated lead levels as soon as possible so as to decrease the risk of continued exposure, I have some recommendations that I'd like to share. I recommend that we continue to do risk assessments for lead at all well checks. I would like to see a routine blood screening done at 12 and 24 months for all children regardless of insurance, and then as needed based on risk assessments. I also recommend that children with elevated lead levels greater to or equal to 5 be eligible for early intervention programs either through the school system or Head Start at age 3 or sooner if developmental delays are noted. I also suggest continued communication between public health departments and the pediatricians around the issues of lead screening, treatment, and follow-up. I hope that by continuing to work together, we can increase public awareness and decrease risk and exposure. Thanks again so much for your time.
Thank you, Dr. Howard. Are there any questions from the committee members here or online? Or comments, if anyone?
Chairman Dempsey. Hi
Yes.
there. This is Dr. Rustin from.
Yes, Dr. Rustin.
Hey, Dr. Howard, thank you for your presentation. It was, I'm so happy to hear that the health departments work closely with you on these types of investigations. I really just wanted to make a comment and for the committee is in that what Dr. Howard has just stated is something that we've heard at public health departments many times, and that negative risk assessment doesn't always mean that the child doesn't have an elevated blood lead level. And the issue of private insurance not covering that 24-month test, if it's a negative risk assessment, has been a barrier for many years. And so I just wanted to go on record thanking you for your comments, because this is something that we've heard many times from pediatricians across the state.
Thank you.
Thank you, Dr. Rustin. Any other comments or questions? Not seeing any, I'll say thank you. You did a great job. It's always good to see you, and we
Thank you.
appreciate your commitment to help us.
Anytime.
Thank you. Okay, so next, Polly McKinney, the Advocacy Director for Voices for Georgia's Children. Polly, even though many of us know you, why don't you say a few words for the record about the work you do?
Sure. I'm Polly McKinney. I'm the Advocacy Director at Voices for Georgia's Children. And I'm sorry, I forgot my badge because it has been a minute or two since I've been down here and I don't know where it is. But Voices is a whole child policy and advocacy organization. We do a lot of research and a lot of policy recommendations and a lot of thinking about how all these different systems intersect in children's lives. And I work at the Capitol here. We have a whole research team back at our shop, as well as the Georgia Statewide After School Network. So we do sort of all things children. And we are not, I will be clear, lead experts, right? So I want to make that very clear that in this testimony, I'm here more to say that we have been watching this issue for a number of years and that we have recommendations that we feel like floated to the top that we would like the committee to pay special attention to. And Dr. Howard hit a number of our thoughts already. So I'll just pull out the couple that we feel very strongly we want to say out loud in testimony. So the fact sheet that you have here is our latest, greatest childhood lead poisoning fact sheet. And the recommendations are on the back in the blue box. And we do, our first and top recommendation is one that you've heard over and over and over again, to update the Georgia law to comply with the CDC standards for childhood lead poisoning. That's a huge issue. We understand that comes with a price tag, likely because there will be more kids revealed to have significant lead exposure. And so, of course, we also recommend working on funding streams for mitigation. We also believe in monitoring and mitigation strategies for women of childbearing age. We've heard a lot about pregnant women, but we feel like the women of childbearing age piece is important, and pregnant women obviously are women of childbearing age. So we can cinch that one all together. The strategies in built environments, we felt there needs to be more intentional design and intentionality around testing in these built environments at schools, childcare facilities, and other locations. And we know there are policies in place, but a sort of more coordinated approach is something that we felt in listening to all of the testimony and things that we've seen in our work would be helpful. And then the points of care, which I think Dr. Howard mentioned, the increased blood level testing sites. So where can kids get tested? And encouraging more testing of younger children. The 24-month non-insurance thing, we didn't call out specifically, but that is certainly one that we would say floated to the top. And then we just really want to emphasize that a lot of kids are not getting tested, right, who should be. And if you look at the little double asterisk thing at the bottom of that second of the backside, it says, we're about, since between 2015 and 2019, Medicaid-led screening rates steadily declined in Georgia by about 12,000 kids, ages 0 to 6. And that's, to us, a flag. So those are that's pretty much all I have to offer. I'm happy to try to answer any questions if there are any.
Representative Manning.
Thank you, Ms. McKinney. You might not be able to answer this.
Maybe not. I'll do my
but-
best.
I'm just wondering, I used to have a childcare facility in a home setting as well as in a commercial building. And I don't recall going through the credentialing process for either location, the state asking me anything about lead testing. So is that a requirement that you know of? Should it be a requirement?
You know, it's my understanding that it is not, but I would defer to the Department of Early Care and Learning to be clear about whether or not that is required in licensure and checking out your facility. We would prefer that it was, but when you do those testings, you have to be aware that there is mitigation that comes with the answers. And I know that the Department of Natural Resources does the water, you know, when you're looking at soil and exposed and lead paint and things like that. I believe that is the Department of Public Health is responsible for those, if I'm not mistaken. But I would defer to the agencies, but I was thinking it was not in the criteria, but I could be mistaken.
Thank you.
Are there other comments or questions online? Not seeing or hearing any. Thank you so much.
Thank
And once
you.
again, you've done an excellent job. This is a very informative piece for us to have and really value the policy recommendations. It always helps us as we go into the next phase of this, which will be to write to write up the report. So thank you so much.
Thank you.
Mhm. Okay. Next on our agenda, we will be joined on Zoom by Rick Andrews with Teradata. And Rick, if you would take a moment and introduce yourself, tell us a little bit about yourself as well. We do have a handout here, but I want everybody else to know a little bit more about you. You are on mute, Rick, if you would unmute, please.
My gosh, you're right.
There
unmuted.
you are. Now we can see you
Hey,
and hear you.
Katie.
Thank you.
My name's Richard Andrews, go by Rick. I work for Teradata Corporation, and as such, we're engaged in a number of projects in Georgia, specifically some around children. Our most notable right now is going live in just about 2 weeks, and that is for child abuse. And what I'm going to be outlining to you is Teradata deals with data. I mean, that's what our core function is. We're a data management company. And in the realm of data, it can provide a lot of answers and a lot of focus if it's properly used. And so what I did was I put together a presentation for y'all. I believe you have hard copies to it. But I'm going to actually, if it's okay, I'll share my screen and actually run through the presentation. I think this is it, share. And let me go to this here. Okay, everybody see it okay?
Yes, yes.
Okay, awesome. First off, I'd like to thank Chairman Dempsey for inviting me to give testimony today, to all the committee members that are there, and then also my learned colleagues that are presenting. I think this is a critical issue. And in getting prepared for this presentation, I learned really how critical this really is, both short and long term, which I hope to share with you. So that being said, and to Representative Dempsey, I would be remiss in not outlining that this is a perfect illustration of the power of GDAC, the bill that you passed with regards to, you know, how data is to be used within the state of Georgia. It's bringing together disparate data from siloed systems for the greater good of Georgia citizens, which is exactly what GDAC was, its intent and designed to be able to perform. That being said, we have a client, the state of Michigan, that implemented a data-driven approach to combat child lead poisoning or child lead ingestion that actually ended up being very successful. And I'll share some of the results of that program a little bit later on. And I promise, Katie, I only have a few slides, so I'm not going to take up all your time.
That's okay. That's good.
Okay. So I wanted to walk through this process because it's really important to understand, and you've heard a lot of this, but how this relates when you're dealing in data might be a little different. So the Mayo Clinic obviously put out exactly what, you know, lead poisoning in humans is, the criticality of it, and what makes it so hard. And there are three real major areas where lead is introduced into humans. Obviously, from a children's standpoint, the lead-based paint chip consumption in older buildings, which is the most acute because it's the most immediate reaction because of the density of the chips and the lead that's in them. But there's also lead-based paint dust within buildings that affects all residents. And we do a great job in our treatment plants when we release the water to the public, but there's also lead ingestion through tap water. If it goes to a building that either has lead piping or lead couplings and joints, lead's reintroduced. So all the efforts within the treatment center become null and void. And one of the things in researching for this testimony that I found really interesting is lead poisoning is really hard to detect. And I'm not talking about it's easy to detect when you're testing for it. It's hard to detect from a symptoms standpoint, because a lot of the symptoms mirror others that are just general illnesses. And it really isn't until dangerous amounts have accumulated in the system where real acute lead poisoning takes effect that long-term issues now become a critical element. So in taking a look from the Mayo Clinic of all the symptoms, I'm not going to run through each one of these, and this has probably been presented to you in multiple meetings, but I wanted to highlight the ones I put in red, because these should be of particular interest, and I'll explain later in the presentation why, but of real interest because they deal with long-term impact that ultimately will be felt by the state, such as developmental delays, learning difficulties, irritability, and mood. As you know, Dr. Howard outlined, the early identification and treatment is the most critical when it deals with lead poisoning. And so how do we use data in order to do or affect a change in this? Well, and I really shouldn't have titled it The Solution, because there's not one silver bullet to anything, especially in public sector, but one approach and critical element to this is to start using the data that you have within your systems and aggregate that data that's in a siloed environment into a central repository. Apply advanced analytics that can make sense and use of this data that is really not associated with each other, but becomes correlational, and then align that to the targeted programs that you put in place to combat actually lead poisoning. So this is a great illustration of how GDAC could play a key role in this. There are 5 primary data sources, and unfortunately, most of these are within totally different agencies that are not associated with each other. But those data sources are vital records, school educational records, Medicaid provider health records, building records, and the poisoning instances reports, or in the case of some of the likelihood of lead poisoning in some of the surveys that you do. Bringing all these together and putting them into a data model that makes it relational, where each can interoperate with each other and apply to that data model an analytics layer, whether it's machine learning or artificial intelligence, that allows you to actually see trends, correlations, associations between data sets that previously you never saw, A, because the data wasn't in one place, and B, because you didn't have an analytic system to actually make those connections for you. And the final piece, and I thought this was really interesting in my research of what happened in Michigan, was a geospatial layer. And I'll explain that. But all of this then feeds down into your lead poisoning program management. And that is a multi-phase, multi-step approach. A lot that's been brought up by the first 2 presenters that allows you to focus your efforts in the greatest area with the greatest return in 2 major distinct areas: a reactive intervention and a proactive interdiction. So how does each data set play interoperable to each other? Well, Vital Records played a key role in Michigan because it related all the familiar relationships that exist within a given household. Because if a child has lead poisoning in a household, it's not a one-off event. There's something environmentally that has caused this. Well, we need to know all the other children that might be associated with this, not just within that nuclear family, but what of all the relatives that could potentially be associated with this? Because they'll spend time over at that household. So it's important to get a grasp of the size of where this outbreak could reach, so you get ahead of the curve with regard to those that could be affected. School educational record shows the potential of lead-based effect on children as they progress within the grade structure, and also shows the impact of it for any remedial programs that you want to put in place to combat. Again, lead being in a system is a cumulative effect that affects cognitive ability later on, and that has a direct effect on the state, and I'll show that. Health records helps identify symptoms for individuals and shared family member diagnosis from correlation to causality. Building record shows the age of systems for potential outbreaks, coupled with the geospatial attributes for tracking all this. And then obviously the existing poisoning reports. But again, the keys to success here is reactive intervention, which is the point of impact where we identify and the treatment plan is done. But what I found really interesting in doing my homework for this testimony was the proactive interdiction. Because one of the things that hit me was there must be a long-term financial impact to this. So what Michigan did is they implemented a data-driven lead-based poisoning approach to this. And from 2003 to 2007, they were able to reduce lead-based poisoning events or treatments that literally had to take place by 35%. They also increased the number of Medicaid enrolled 3-year-olds for screening from 50% to 72% in a 6-year period. And what I thought was interesting, and this is where the geospatial comes into it, they were able to identify specifically 14 Michigan communities that represented over 80% of all child lead poisoning cases. That allowed them to put very focused programs in those communities specifically to combat this. And then finally, it helped identify for the health plans, the children most at risk and that need to be tested and that required continual follow-up. Now, as I said, one of the things with any social services, we at the state level, we're the tip of the spear. We're the ones that provide on the street, boots on the street, the type of services in order to help our constituency through the multiple things that they're faced with. Unlike the feds, we don't get to print money either. So we have to be good stewards of what we invest in, how we invest, so we get the greatest return over the limited resources that we have. So it hit me when I was getting ready for this presentation. What is the financial impact of lead poisoning, but not just the treatment plans? I mean, it's $3,000 cost for treatment plan on an acute lead poisoning. Well, that doesn't give me what the real costs are over a term period. And so in going through and trying to find some studies that I was investigating, I came across the Columbia Law School Health Advocacy, and I couldn't fit it in, Judiciary Clinic that was actually written for the state of Georgia. I included the website on here. It's an 8-page report over the cost ramifications of lead poisoning. And I got to be honest with you, I was shocked to find out or to see their assessments of what the cost metrics were. And I included in this just a blurb towards the top of that report that for one cohort, or in data scientist speak, that's one grouping or one entity of children aged 1 to 2 years old who had estimated EBLs above CDC reference value, the cost could be as high as $212 million over the lifetime of that child. And this is found in all the social service programs that now had to be applied to these children, either because we didn't screen for it, catch it early enough to where there was long-term impact to this individual as they went from into young adulthood and beyond. So they could be in housing vouchers, it could be in social services costs. And their view is the taxpayers would shoulder about 26% of this. That's over a lifetime, $55 million. Now, I implore you to read the study and make your own assessments of their view of the cost and the breakout. But even if you took $55 million of what they're saying and cut it by 90%, you could pay for a number of the programs that you're looking to implement and this system, and it would pay for itself in under a year. Now, understand, in this study, this is one cohort, one grouping. That grouping doubles every 2 years because you get another 1 and 2 year old enter into it. So when you look at the cumulative effect, it's pretty prolific. And then I'll close with, this is exactly what GDAC legislation was passed for. It's addressing critical social problems with data that the state already has in its possession. There is not one data set that I've outlined that you don't have up and operational. And quite candidly, this could be imported and put to use to combat this very serious issue. And that's my presentation.
Thank you so much. Representative Gamble.
Thank you, Mr. Andrews. Enjoyed your presentation. My question would be, I know you used Michigan as the example. Are there other states that have a similar system in place? And is there any kind of general idea on the cost of something like this?
That's a great question. I'm sure that there are other states that have approaches. I'm not aware of one that did it like Michigan, and there's a specific reason. Because, and then we all know public sector, every agency is very guarded with their data. And so they house it in their environment. And it's very rare that you see agencies work together in the manner that Michigan does, but Michigan's business model was one central agency for all data. So for them to interact and implement this type of approach was much easier to do, where you didn't have data sharing agreements that you even had to worry about. I'm not aware of other states that have been able to achieve that. Although in Georgia, which is a great sign, Georgia sees the value in this because it's exactly the same data sharing agreements we're doing for the child abuse calls. So you're willing to actually go down this pathway. In regards to the second portion of your question, cost. With all candor, you're looking at under, I hate being asked that question, by the way. You're looking at under something over a 3-year term of about $4 or $5 million. And if, as I said, you run the numbers, that pays for itself in 7 months. And by the way, as Katie will attest to, because she was involved, she sponsored GDAC. Now all this data that you consolidated can be used for all the other business questions you have, which is the real value because it's cumulative. Once you bring the data together, you can start asking a whole host of other questions.
Great. Representative Maynard. Are you on? Oh, what number is it? It went away. There you go.
Mr. Andrews, thank you for the presentation. What I really loved about it is, there are two schools of thought. If I just had to divide human nature, there are people that are economists that look at numbers, and then there are humanists that look at the human toll of people. And so what this presentation does is it provides an avenue for both types of people, right? And so I appreciate that using GDAC and data, which is so relevant today. And I'm so glad that Georgia is using data in ways like this. But what can happen is we can actually save money by helping people. And a lot of times when we look at helping people, especially disadvantaged people, some people may look at that as, that's not in my backyard, I have nothing to do with it. But when you're talking about the whole state of Georgia, and you look at how much money Georgia can save, then I would hope economists, when we start putting out bills for this, I hope the economist type would say, you know what, with the $212 million we save, we can put this towards another avenue. So I really appreciate the presentation.
Thank you very, very much. And I 100% agree with you that the most important point here is we protect children. I mean, that is really all my interface to Georgia. But at the same time, if we can be good stewards with state finances while we do it, that's a win-win. So I thank you for your comments.
Thank you. Do we have any more comments from the members that are joining us online or questions? Not seeing any. I want to say thank you to you, Mr. Andrews, particularly. And I want to thank Cynthia Garst, who represented y'all here,
Yes.
for letting us know about the success in the Michigan project, and that you could really add some important testimony to the discovery process that we're in right now. I also want to thank you for all the work that you and also other providers of similar products worked with us on to get us to the GDAC place we're in right now. I actually had a meeting right before this meeting with DFACS. We're about 2 weeks out from changing to light speed, the way that we are going to be dealing with lives that we hold in the DFACS process. It's very exciting. We're about 2 weeks out from doing that. So I want to thank you for the work and for the ways that you helped me be smart enough to champion that. It was a great process, and it's good to see how we could once again use that similar integration of breaking down the silos, and that now we have the capacity to do that. And like you say, to pull together information that we already have, create some new, add it in there, and really make a huge impact on this life impacting issue that we are dealing with. So thank you for presenting. It's good to see you. And I really appreciate the investment and the opportunity that you and Ms. Garst and everyone brought to the table to help us get to this place today. So thank you.
Thank you very much. I appreciate it.
Good to see you.
Good seeing you.
Okay, so next, Jenny, I hope I'm going to say it right. Holroyd. Holroyd, thank you so much. Thank you for joining us today. Principal Research Scientist and Manager of the Occupational Health Group at Georgia Tech. If you could tell us a little bit more about yourself too, as you get ready for this presentation, that would be great.
All right. Thank you, Chairman Dempsey and all others for having time for us. My name is Jenny Holroyd. I work for Georgia Tech as a certified industrial hygienist in a program that I'm going to speak to more later, but I come to you today as representative from the Georgia local section of the American Industrial Hygiene Association to really discuss the role of childhood lead exposure and the potential for that exposure to be coming home with the parents from their occupational health exposures. So many of you may never have heard of an industrial hygienist before. That's common. I don't know that some people have ever heard of that, but what an industrial hygienist is we basically go out to companies, all different sizes, and we do air monitoring and noise monitoring, and we look at the exposures that are in the air and on surfaces that are produced from the tasks being done at the job, which means that industrial hygienists have technical expertise when it comes to performing air monitoring and air sampling services, as well as wipe sampling to assess lead exposures in all environments. What we do is we work directly with businesses to help them with compliance with regulatory agencies like the Occupational Safety and Health Administration to provide guidance on work practices and controls to reduce worker exposure and to also prevent take-home exposure. Another facet we do is to interpret exposure monitoring reports and provide additional expert reviews of data. So that's looking at whether or not the exposures in the air in certain environments could potentially lead to cross-contamination in other environments. We also spent a lot of time developing training and documents, of which I brought one to share with everyone that they can take at the end that we worked with the Department of Public Health to develop. So there's many programs in the state of Georgia already that exist that can assist with this potential, what the committee is working on right now. One of them being the Georgia Lead Alliance. And this is an alliance between the Occupational Safety and Health Administration, the Georgia Department of Public Health, and Georgia Tech. And the group within Georgia Tech that is working with them is the group that I work for, which is the Safety, Health, and Environmental Services group, which is housed within the Enterprise Innovation Institute at Georgia Tech. So kind of giving you a framework where we are, but we do that with funding from OSHA. And so for over 42 years, Georgia Tech has been receiving funding from the Occupational Safety and Health Administration to provide free on-site compliance assistance to small businesses. What this means is we help what's powering the state of Georgia stay in business and stay safe and healthy for their employees, keep the environment safe and healthy for their employees so that they can have sustainable work environments. Through the over 16 years that I've been working with the program, have gone to a variety of environments where lead exposure is one of the primary exposure routes. And one of the most important factors that we discuss is bringing home the exposure on their clothing and on their hands and in their cars and on their shoes into the homes where they may have children or pets that may be exposed to the lead exposure. It's not just workplace exposures, it's also a variety of hobbies and crafting that can cause exposure to lead. There's also the Georgia local section of American Industrial Hygienists, which is a very active group of industrial hygienists that are always looking to be of assistance to providing guidance and support. And then the variety of services that are provided through the Georgia Department of Public Health. Oftentimes, we spend a lot of time looking at the services that are specific to children within the Department of Public Health, but I encourage you to also take advantage of the variety of documents and resources available through the Occupational Health and Safety Surveillance Program within the Georgia Department of Public Health, housed within the Department of Epidemiology, that provides businesses guidance related to lead exposure. So this is our task as an industrial hygienist, is to prevent the exposure at the source. So the employee is working with exposure at lead, and there's a variety of ways they could be. They could be working at a shooting range. They could be producing lures for fishing. They could be working in robotics, where the main source of solder in the circuit boards is lead. They could be working in recycling environments. They could be working with electronics, car manufacturing, battery manufacturing, or construction. Recently, I've been on several projects where the exposure to lead was a result of an installation of lead-lined sheetrock in hospitals, which is really critically important because it allows them to do patient-based X-rays and services in the patient's room, but that means that the amount of lead-lined sheetrock that's being installed in hospitals being developed now is exponentially larger than we saw in the past, when there used to be just one room where radiology would be taking place. So how the worker ends up getting exposed is they get it on their hands, their shoes, their clothing. They bring it home, they hug their kids, they kiss their kids, their wives or husbands wash their clothes in the washing machines, and when they pull them out, there still may be residual lead exposure. And that is how we have that transfer. And so what happens, and one of the reasons why we started the Alliance, is that lead exposure, high lead levels, are reportable to the state Department of Health. And we have been trying to close the gap that when an adult tests high for lead, we circle back to the place of employment and try to provide additional guidance. A couple things that I made note of while I was listening to the previous presenters is that the question for pediatricians to screen children, whether or not they have exposure to lead, relies on the parent knowing that they have lead exposure at work. There is a question related to work-based exposure, but that is also relying on the fact that the employee received hazard communication training, which is required by the law from OSHA, that there's lead exposure. So there's the potential that the employee, in my mind, or the parent in the pediatrician's office, is completely unaware that what they're doing has exposure to lead. Another thing that I think was important to mention is there are a variety of occupational exposure data sets that could be integrated into this data integration. And I am woefully unaware of which ones are involved yet, but I encourage the occupational exposure metrics were added to the BRFSS survey. And so that is one avenue that you could be gathering information about potential exposure. You could also potentially look at workplace workers' compensation data claims for exposures to lead and integrate that in to then follow back to make sure that children in the homes where there was exposure to lead are not also being exposed. And so I wanted to keep my comments brief, but I am open to any questions or additional insights you may have. So thank you.
Thank you. Are there any comments or questions here or from the members that are joining us? Okay, Representative Mena.
Just a quick comment. Thank you. I think that's really interesting because we've had so many meetings about lead exposure, but we really haven't talked about cross-contamination. And just coming from a healthcare provider perspective, especially in home health, there are all these universal precautions that you have to have in order to not have cross-contamination from home to home, and to just think about contamination from the workplace into the home. So like, for example, during COVID, when healthcare providers come home, they might take all their clothes off before they enter into the home. But now, to your point of just the mobile x-ray testing within the hospital,
Mhm.
I don't think that people are really even thinking about that. And so thank you for just shedding light on it.
And just to clarify, once it's installed, it's no longer hazardous.
Okay.
So for the nurses going into those rooms, it's fine. It's the construction workers. And if they're not aware that there's lead, one of the things that an employer would be required to provide is showering on site before they go home. And I will tell you that is a very hard behavioral task to make a worker shower before they go home. Even if there are resources available, but most construction sites, that's extremely limited. I, as an industrial hygienist, will come into my garage and completely strip down and run into the shower because I want to keep that contamination outside, but I've had years of training, whereas an employee may not have had that.
And then if you think about the construction workers being non-compliant to showering and thinking about who the population of construction
Mhm.
workers are, I think that's unfortunate. It's a carryover effect to populations that probably are already in dire need of just healthcare and don't know about lead
Right.
exposure as well.
And we would refer to them as vulnerable workers because there's typically language barriers as well. And so that would be an added problem. Thank you.
Are there any other questions from those that are joining us online? Not seeing any. I want to say thank you too.
Thank you very much.
That was very informative. Like Representative Maynard said, a different perspective that this is the first that we've really brought that into this conversation. Recently, I was in a little bit of a traffic spot, but right next to an industrial construction site. I mean, right next to it. And it was quitting time. And I noticed for the first time that as some of the workers came out, and they were pretty much in clusters getting into their car, they were taking their shoes off. I noticed this and I saw them put them in there and pull out other shoes and put them on. I don't know if they pulled them out from the same site. And I'm not saying that lead was involved, but in my mind, I thought, oh, how nice, they're going home, or they don't want to get the person that they're carpooling with, get their car dirty, But now I realize that in some cases, it may be much more of a prevention effort that perhaps they've been educated to respond to. But that was very interesting. Kind of pulls together a lot of things that I've seen lately. So thank you. Thank you so much. Okay, so moving. Oh, and before we move from that, I want to thank TJ Kaplan too for bringing you. And earlier when Dr. Howard was here, that was Rick Ward with the American Academy of Pediatrics, Georgia. It is all of you that have been listening and paying attention and care so much about children and families. I just really appreciate your sending people in to help us look at this with wisdom. So next we have Elizabeth Apley, and Elizabeth represents the Enterprise Community Partners from the Southeast Georgia, Advancing Communities Together. Elizabeth, I know a lot of people here know you, but please tell us a little bit more about your work.
I would be happy to. Thank you, Madam Chair. Let me get set up. And I need to share my screen. Jenny, how did you do it? Oh, I got it. Okay, there. You can see tech is not my strong suit. So I'm an attorney in practice. Oh, I guess it's coming through. I think we've shared. Thank you. Can only do one thing at a time. And so Georgia Advancing Communities Together is a statewide organization that works to advance opportunities for safe, healthy decent, affordable housing and addresses homelessness as well. I also represent Enterprise Community Partners on this issue, which is a national organization with an office here in the Southeast that covers the full gamut of financing, construction, advocacy on housing affordability and homelessness. So we wanted to start by thanking you, Madam Chair, for your leadership over these years to bring this healthy housing study committee together to address lead poisoning in children. To the members of the committee, y'all have been working very hard. The testimony has been amazing, and I've learned a lot, and we appreciate the time to be with you here today. I was 2,000 years ago when I was in law school at Columbia, I was a member of the Health Advocacy Study Committee, but I didn't know about that report that Mr. Andrews shared with us, and I'm looking forward to reading it. And I also wanted to thank the committee. Dr. Robertstein, our first witness, mentioned the fact that some parents, either inadvertently or intentionally, will limit the statement of lead exposure in their screening document because of the fear of what it would threaten their housing situation. And of course, we're talking about housing situations that are the least safe and least stable for children who are most exposed. And you can thank and congratulate yourselves for having passed 2 years ago legislation that for the first time protected tenants from being evicted in retaliation for raising issues about the health and safety of their rental apartments. So thank you for that. And hopefully we can put that to good use in helping families to be more forthcoming in those screening documents. So like Polly, I am not an expert in lead, nor do I play one on TV, but I have been diligently researching this issue and listening to the excellent testimony, and I'm trying to focus my comments today on recommendations to prevent and ameliorate lead poisoning in children. So the old adage, an ounce of prevention is worth a pound of cure, is exactly what the CDC says. Primary prevention, the removal of lead hazards from the environment before a child is exposed, is the most effective way to ensure that children do not experience the harmful effects of lead exposure. And when we're talking about blood lead screening tests and secondary prevention, also an essential safety net for children who may be exposed. But those distinctions are important to keep in mind. Primary prevention focuses on removing lead hazards from the environment before the child's exposed, and it is certainly the most effective way to prevent lead poisoning. The secondary prevention strategies include the blood lead testing that is so important, the follow-up care and referral, and to bootstrap with the data that Mr. Andrews shared, preventing childhood lead exposure is very cost effective. The Health Impact Project says that eliminating lead hazards from the places where children live, learn, and play could generate approximately $84 billion in long-term benefits per birth cohort. And permanently removing lead hazards from the environment would benefit future birth cohorts, and savings would continue to grow over time. So when we talk about primary prevention and secondary interventions, we want to focus first to protect children by education and outreach, effective code enforcement, and rehabilitation of properties to make them lead safe. And you're going to hear in a few minutes from Emily Lundgaard, who is with Enterprise Community Partners in Ohio and is the facilitator and manager for the Cleveland Lead Safe program, which is a best practices model in place now to make housing lead safe before children are poisoned. And I'm really excited that we were able to bring her to you. Secondly, and as a secondary intervention, we want to expand and strengthen the interventions that address the consequences of lead poisoning, increasing screening, providing case management, and of course, abating those hazards that have caused lead poisoning. I want to share with you that the American Rescue Plan Act, the federal law passed by Congress this year, has brought many billions of dollars into the state of Georgia. You may not be aware that ARPA funds are expressly available to provide for lead abatement. The interim regulations that have been issued note that children have spent more time at home during the pandemic, creating greater risk of exposure to lead. And at that same time, and I'll share this data with you, the testing and referral and abatement for lead poisoning were decreased dramatically. Keep in mind that those children who are most disadvantaged from these circumstances caused by the pandemic were most disadvantaged going into the pandemic. So I refer you to that language in the interim federal regulations about eligible uses to address disparities in public health outcomes. And I quote here, housing services to support healthy environments, healthy living environments and neighborhoods conducive to mental and physical wellness. In addition, specifically remediation of lead paint or other lead hazards to reduce the risk of elevated blood levels among children. So Georgia has billions and billions of dollars, and we can use them to help address this significant public health disparity and COVID-related problems. So ARPA funds can be used for lead abatement, implementation of lead-safe housing programs, strengthened screening and reporting, remediation of mixed screenings and follow-ups during the pandemic, and as well as increased outreach and education to parents and healthcare providers. So we would also urge, as Polly mentioned earlier, to adequately fund the Department of Public Health and DNR's EPD to perform these lead investigations, abatements, and certification and licensure of inspectors and contractors. I think we heard testimony that 90% of these contractors doing work are not now certified or licensed. You just heard from our expert on industrial health that there's widespread lack of information. So we need to strengthen that. And we need to strengthen the capacity by funding it for meaningful enforcement against those not licensed to perform this work. So we want to address screening adequacy and gaps. You heard Dr. Geller testify about the gap between the actual findings of elevated blood levels and the expected findings here in Georgia. And recent research conducted by the CDC over a 7-year period showed Georgia lagging each year against the national averages, both in the percentage of children under 6 who were being tested and the findings of elevated blood levels in the children on a statewide basis. Nationwide data also shows that adherence to screening requirements is low, that 40% of Medicaid children are not receiving these screenings despite the EPSDT requirements. And Georgia has no statutory requirement for lead testing, although research shows that the stronger a state's policy in testing and reporting, the more likely you are to have a higher number of children tested and to find more children with elevated blood levels. There are 10 states out there, and there may be more now. This research was a little old. 10 states require universal testing, generally for all children at age 1 and 2, including Louisiana. 8 states require targeted testing, including Virginia, and we are part of those 27 states that include only recommendations. So the best practices for screening, as you've heard, are to strengthen strategic education campaigns, both for providers and patients, to make testing more accessible and affordable, As you know, the Affordable Care Act requires covered healthcare plans to fully cover lead screening for children who are at risk of exposure. And some states have taken the next step to impose that requirement on insurance policies that aren't covered under the ACA. And some states are offering free or low-cost tests at local health departments for underinsured or uninsured children. We want to get more information, and I believe Dr. Geller pointed this out, the gap between children being referred for a lab for testing, and I believe the doctor mentioned this also this morning, being referred to a lab, never receiving the test. We want to know where that's happening and figure out strategies to address that problem as a critical way of making sure that we're screening everyone. And this is going to echo what we heard from Mr. Andrews. Suggestion is being made by the experts to publish data on the tests done at 1 and 2 years, and to provide for data sharing to identify the gaps, and that information will allow us to fix it. I wanted to share with you some of the data on COVID-related screening declines. They've been quite dramatic, not surprisingly. I think that Polly referred to the fact that we've had declining levels of testing overall over a period of years, but the CDC looked at 34 jurisdictions, looking at the first 5 months of January to May in 2020, comparing that to the same months in 2019, and found a nationwide drop of 34% in testing. Georgia had a decline of 11,700 children during that period. And if you look at the data that the state reports, Department of Public Health reports, there was almost 24,000 fewer children tested in 2020 compared to 2019, with almost 400 fewer children identified with elevated blood levels. Clearly, during COVID, there was a problem with referral, follow-up, environmental investigations, and abatement. And so remedial action is recommended in order to address all of those COVID-related gaps. Polly mentioned, and you've heard testimony from a number of the witnesses about the need to address lead in childbearing women. And we do use that language intentionally. There have been recommendations to extend the law to include pregnant and breastfeeding women in a number of the code sections cited. However, the experts tell us that lead exposure at 5 or above affects approximately 1% of women of childbearing age. And we also know that you really can't do as much as is needed in many cases to treat elevated blood levels once a person is already pregnant. And so in order to protect the fetus in utero and the infant who's breastfeeding, it's really best to identify those elevated blood levels before the woman becomes pregnant, or at the very least at the earliest possible point in the pregnancy. Nonetheless, there's not a requirement for universal testing of all women of childbearing years, but we have to look at ways to address this problem in order to be better focused on preventing women from having elevated blood levels during pregnancy and breastfeeding. So we all know that it's going to be critically important that we update the definition of elevated blood levels here in this state to conform to the CDC standard that was adopted way back in 2012, reducing the level that triggers intervention from its current standard at 10 micrograms per deciliter to 5 micrograms per deciliter. And in fact, We've heard that the CDC is looking to reduce that number further because their number, that 5 micrograms per deciliter, is tied to national testing that evaluates where 97.5% of children are. And that's how they chose that number, and that data keeps being updated. I note here that 37 states have already adopted this standard, and we hope Georgia will too. By doing that, you're going to trigger the opportunity for the Department of Public Health to take action to intervene, to help children without the requirement of follow-up blood testing, and that's consistent with CDC guidelines. We've heard a lot of testimony about lead in the environment, in the yards and playgrounds where children are exposed to lead outside the home. But our current definition of the law defines dwelling unit, or residential housing unit to mean the interior of a structure, all or part of which is designed or used for human habitation. So we need to expand that definition to include the interior so that the rest of our statutory obligations will apply when children are exposed outside their front steps. We would urge you to update the blood level necessary to trigger the obligation for abatement in order to meet current scientific standards. You can see that Georgia law now provides for the removal and correction of a specifically identified hazard only when there's a confirmed lead poisoning, which is defined as 20 micrograms per deciliter or 15 to 19 micrograms per deciliter in 2 tests taken more than 3 months apart. So the trigger should be to conform to that 5 micrograms per deciliter and without the need for repetitive venous testing in order to allow the Department of Public Health to serve children who they can't now serve. Likewise, and the department has recommended this, we would urge you to consider the definition of lead hazard abatement under the law. It should be eliminated as it exists in 3141.12 5.1. It's unduly restrictive, it's unhelpful, and it should be replaced with the DNR definition of lead hazard abatement, which reflects meaningful practice. And that is that abatement is a set of measures designed to eliminate lead-based paint hazards in accordance with standards adopted by the board. Again, we urge you to consider updating the definition of a lead poisoning hazard in order to meet the scientific standards as defined by the EPA. And you see here now under Georgia law, in order to constitute a lead poisoning hazard, which is what you have to do in order to abate, you have to reach a level of exposure for accessible or mouthable lead-bearing substances many times what the EPA recommends. You heard the department testify that Georgia's definition of lead dust hazards on floors is 10 times higher than the EPA definition. The windowsill definition is 5 times higher. So those need to be brought in line with current science. And we would also urge, as the department did, the elimination of the definition of persistent elevated blood level. Scientific standards would say that repetitive testing over a period of months is not necessary and only delays beginning to address the solutions that are needed. We would also recommend that you include childcare centers in the duty to abate lead hazards found on site without requiring as current law requires, persistent elevated blood level. And you see that that ties back to our request that you eliminate that definition. You would also note that in order to abate lead hazard in a childcare center now, you'd have to find levels of 15 to 19 micrograms per deciliter in tests performed over multiple tests performed over 6 to 12 months, all the while young children are being exposed to a known hazard. So I'd like to turn to closing the loopholes that now exist in the abatement obligations. One of the requirements under existing law requires that before you can impose an obligation to abate, you have to, quote, confirm that all other potential sources of the confirmed lead poisoning have tested negative. Well, I think that's impossible. But the reality is that once you have a confirmed elevated blood level, and you have confirmed that there is a source of lead in the home or in the child care center, it should be abated. And if it's found in additional locations, those should be abated as well. We also support the department's recommendation for a post-abatement clearance to be conformed in conformity with EPA standards, which would mean that the visual inspection now permitted under Georgia law be eliminated. I think the witness testified specifically, you can't see lead. And so that form of testing for abatement compliance is not valid and wouldn't meet EPA standards. And finally, strengthen the definition of maintenance standard to meet scientific criteria, because this is listed as an alternative to meeting the obligations for abatement under existing law. We recommend strengthening enforcement by the imposition of penalties, fines, et cetera, for failure to timely abate. And this is not a new idea. In 2004, the Department of Public Health contracted to have this organization called Healthy Housing Solutions to provide what they called a childhood lead poisoning in Georgia needs assessment. It was required by federal law at that time. And you'll find on page 13, they're noting that while there are several useful provisions in Georgia's law, it falls short of the authority needed to enforce an order to property owners to abate lead hazards or to enforce recommendations contained in a lead inspection or risk assessment report. It says, even though the act establishes deadlines for submission and approval of hazard abatement plans, there is no fine, sanction, or penalty for failing to abate the hazards. And they note that the regional lead coordinators and others have noted that current lead hazard control efforts fall flat when there is not enforcement or compliance authority. And finally, we urge you to consider revising the immunity now provided to property owners under OCGA 314115 to conform to reasonable standards of negligence law. So that was a mouthful. I can't say enough about the leadership of this committee, of the Department of Public Health. Really, we're only trailing their leadership and trying to help and add our research to that mix. And I'm ready to answer any questions that you may have.
Well, thank you. That was a very informative piece, and it's going to be good for us to have this as we move forward.
And I included the hot links in there so that rather than footnotes, so that you can get it from the horse's mouth, right?
Wow, appreciate that. Thank you so much. Representative Maynard.
Chairwoman, Attorney Apley, it was just so extensive. Thank you for all of the information. I have a couple questions. So under primary prevention and secondary interventions, you list education and outreach, effective code enforcement, and programs such as the Cleveland Lead Safe program. For effective code enforcement, when I look at the ARPA funds to prevent lead abatement, I don't see the code enforcement. So can ARPA funds be used for code enforcement?
I believe that they can. I took out the language that was most directly on point, but in many states, code enforcement is a key part of the enforcement of healthy housing. We have many challenges with code enforcement in this state. One of them is a lack of adequate funding, and this testimony was very clear when we were working on that legislation a few years back to ban retaliatory eviction for people who are complaining to their landlords about unsafe and unhealthy housing conditions. What we found is that people were routinely evicted once they made that complaint, that if they made a complaint to code enforcement and then were evicted by the landlord, their complaint would be closed without a resolution, and then the landlord would immediately rent that apartment again. We also found that there's a provision in Georgia law prohibiting the registry of rental property and requiring that cities or code enforcement could only act based on probable cause defined as what they could see from the street. Well, as you can imagine, you can't see lead poisoning from the street. The city then is unable to initiate a code enforcement action unless the tenant, him or herself, makes the complaint. And of course, then we start that cycle of the retaliatory eviction.
So, and let me ask a follow-up question to that. So for the code enforcement and ARPA funds, I know a lot of times, to what your point earlier, localities are underfunded with inspectors, right? It's just not enough inspectors.
Yes.
And so can ARPA funds be used to hire more inspectors, train inspectors?
That's my understanding. And, in addition to the $4.8 billion that Governor Kemp has received the authority to allocate, entitlement jurisdictions, cities and counties have received directly funds to meet the needs of the pandemic and the populations most affected by the pandemic. And so that first language in that slide that deals with healthy housing and healthy neighborhoods clearly goes to the question you're posing.
Okay, thank you. And then
Oh, that's a long way of saying yes, I think.
I have another question. So, the thing about, we have been receiving so much money
Yeah.
from the federal government, and oftentimes it's so much money, the recipients don't know what to do with it, right? And
Yes.
what happens is sometimes the money just goes right back. And so want to make sure that, Georgia's not sending any money back. So for another.
And you're right. The research is showing that cities and counties have not started spending that money, and they have a number of years to do it. There are, different limits on different pots, but yes, that is very important that we show leadership in making recommendations for best practices about how it should be spent.
Right, I agree. And so under your best practices for screening,
Mhm.
some states provide point of care screening machines free to selected practices or health departments. Is that, again, I'm going back to this money coming down, can they use?
Absolutely,
Okay.
absolutely. Addressing public health disparities is one of the big block components for eligible uses. And we know that when you're talking about childhood lead exposure, you're predominantly talking about disadvantaged communities who are already suffering health disparities, and they're absolutely COVID related. And so that it would be permissible. But I don't have the expertise, and I believe Dr., and I'm blanking on her last name, Robert Steen. I know Robert Steen's her first name, but
Howard.
Howard, one of those hard names, Howard. She mentioned this issue about the testing on site and referring to the labs. And Dr. Geller addressed it as well, that I don't know what the machines cost, but how to address that so that we're not in the position of referring someone to a lab and they're never showing up, and the family not getting the counseling that needs to go along with the finding of an elevated blood level. We have to address that.
And if I can do two more questions.
Of course, of course.
So under addressing lead in childbearing women, it just made me think about a few years ago, probably more than a few years ago, how HPV testing in teens became, I don't know if it's mandatory or just recommended, but it just made me think when you're thinking about childbearing women, oftentimes we're looking at pediatricians, but maybe it might be worthwhile to be looking at it from an OBGYN
No question. You're right.
perspective
Absolutely. That's what we mean.
as well. And then the last thing is the update Georgia law on abatement. Just thinking about the dwelling, it made me think about, again, just coming from a home health world. Oftentimes when healthcare workers, social workers go into people's homes, they are required or mandated by law, especially if they note abuse and other signs like that.
Yes.
But also when you go into these homes, you see problems in the structure. And you see, I can recall literally, I opened up someone's door one day and the frame of the door kind of crumbled. And there were paint chips, falling as well when I'm thinking in retrospect. And so just thinking out loud, right, is that there also may be an opportunity for home health workers or in-home workers to also have an avenue where they can report such things as well.
Yeah. You're absolutely right. I would mention that Georgia law for more than 25 years has provided that it is the policy of this state to provide access to safe, decent, and affordable housing to all segments of the population. And it's clearly a policy that we're not carrying out. And so that's why I'm happy to mention the ARPA funding to help us combined with our massive budget surplus, our $2.2 billion of unobligated funds, to use that to begin to address. I think that people are aware now of the consequences of a lack of safe, decent, and affordable housing. It impacts a child's ability to benefit from an education, of a parent's ability to work, of our ability for communities to stay safe, for us to prosper in jobs and every other aspect of successful community measure that we have. Thank you.
Thank you. Yeah. Are there any other questions or comments from anyone joining us online? I'm not seeing any. Thank you. This is great information for us to have as we move forward. Appreciate it.
Thank you. And I'm looking forward to y'all hearing from Emily Lundgaard.
Great. And that is who is up next. Emily Lundgaard, the Senior Program Director from Ohio Enterprise Community Partners. She's going to be joining us by Zoom. Emily, let's see if we can connect with you.
Good afternoon. Am I coming through?
You are. We can see you and hear you. Thank you so much.
Oh, wonderful. Good afternoon. I really appreciate the opportunity to be here virtually, coming to you from Cleveland, Ohio. I just wanted to start first by saying it's really extraordinary that this study committee has come together and convened on this important issue of lead poisoning. Really want to commend you on behalf of the entire state of Ohio. So thank you for this work. I'm Emily Lundgaard, Senior Program Director for State and Local Policy at Enterprise Community Partners. If you don't know us, Enterprise is a national nonprofit that exists to make a good home possible for the millions of families without one. I work here in Ohio. I do have a colleague down in Georgia, Candace Mitchell. You may know her, and we have peers that work across the country. I'm here today to really focus in on the work that Enterprise does to facilitate the Lead Safe Cleveland Coalition. It is our community's effort in Cleveland, Ohio to prevent childhood lead poisoning. I'll talk a bit about the coalition in a moment here, but first I wanted to just quickly explain Enterprise's role. We're a housing organization and we've stepped in to really be facilitator, the backbone organization of the Lead Safe Cleveland Coalition. So that includes all sorts of things from marketing to media facilitation to fundraising to relationship management. We're really the ones organizing it and moving the work forward. So with that, I'm going to pull up some slides if that's okay.
Yes.
Please do let me know if you're able to see these.
We are seeing them. That's
Oh,
great.
wonderful. Well, I'll dive in here and share first some background on the Lead Safe Cleveland Coalition. So like I said, the coalition is facilitated by Enterprise, but we have been around for a number of years, and we actually formally launched back in 2019. The photo you're seeing on this slide is actually our official press conference from Cleveland City Hall. Fast forward to today, we have about 500 members from every sector and walk of life participating in our coalition. That includes residents, landlords, housing organizations, healthcare institutions, community development organizations, government at every level, philanthropy, and even private sector folks. And while everybody is from different backgrounds, we really do share the same guiding belief, and that's that no child should ever be lead poisoned within the city of Cleveland. We are a true inclusive working coalition. We are not a 501c3, which is important because it means we're all taking time out of our schedules, our priorities to dedicate to this work. We have a number of working committees and subcommittees, and we cover topics from policy to research and evaluation, community engagement, to even specific work like creating lead-safe childcare settings. We partner with the City of Cleveland, but it's important to note here that the City of Cleveland does not lead this work. It is a genuine public-private partnership. It's not just in how we run our work at the coalition, but it's also in how we fund it, which I'll talk about in a little while. So the public-private piece is something you'll hear me say a lot more on. And finally, I'll just mention that while we are focused on work within the City of Cleveland, we are beginning to replicate our work in other parts of Ohio and frankly across the state in general with the support of our state legislature and our governor. So with that, just some quick background on what the crisis of childhood lead poisoning looks like here in Cleveland, just to ground you a bit in our context. So on average, our childhood lead poisoning rates are 4 times the national average. We've actually commissioned a Cleveland specific study through the Case Western Reserve University. They did a review of all the long-term consequences of lead poisoning, and the results, as you would expect, are staggering. We found that Cleveland children with elevated blood lead levels are 27% lower chance of being on track for kindergarten. They are up to 30% more likely to enter the juvenile justice system, 34% more likely to be incarcerated as adults, and by the age of 23, far more likely to have relied on public assistance. And, you know, I'm not even touching upon the disproportionate impact on Black and Brown families, which I think we can all know and understand well. You know, and the reason we know it, I should just add here, is because what we've found when we've spoke to folks all across the country is that this is not unique to the city of Cleveland. This is something that we're seeing in cities across Ohio, big cities, small cities, but also in rural parts of our state as well. And then we talk to folks in other states and they're really feeling the same long-term downstream consequences of lead poisoning. You know, one of the things that I want to say, and this will be one of my first big takeaways here, is that this is especially concerning, and I'm sure you all know this as a study committee, because no amount of lead is safe in the bloodstream. What you're looking at are pretty dire long-term consequences, and that is often the case because of a very small amount, sort of a staggeringly small amount of lead exposure. You know, we often like to put it in context for folks by saying it takes the amount of dust to cover your fingertip or sugar in a sugar packet's worth of lead dust for a child to ingest to have irreversible effects from lead poisoning. This is often why we focus on prevention. We want to get upstream before a child is ever exposed to that lead dust or lead hazard, so they're not dealing with these long-term irreversible consequences of lead poisoning. So the first thing I really wanted to underscore is this idea of prevention. We, through the Lead Safe Cleveland Coalition, are trying to prevent childhood lead poisoning. And we do that through what we call a public health crisis with a housing solution. So we do that by addressing our housing stock. In Cleveland and in many other parts of the country, it's actually lead-based paint in homes that is responsible for poisoning our children. It's, as Elizabeth said, often invisible to the eye. It is not just chipping and peeling paint like you see in this photo, but it is invisible dust that's created on friction surfaces. Maybe it's a door or a porch that's creating enough dust for a child to ingest and be poisoned. And, our housing stock is particularly vulnerable if it's built before 1978, the year that residential lead-based paint was banned in the country. Well, in a place like Cleveland, over 90% of our housing stock was built before 1978. So you're starting to get a sense of the scale and scope of the crisis and why it does look particularly bad in our city and other similar cities and states. So the whole idea, again, on prevention is getting to really fixing hazards before a child is exposed to them. So extrapolate that out. What we're really saying is, how can you fix homes and make them safe before they ever have an opportunity to poison children? And for many, many years in Cleveland, and I think this is actually something that we see in a lot of other places across the country, the idea of abating all of these homes that have lead-based paint in them is insurmountable. It's not only just incredibly expensive, but systemically, how would you remediate that many homes? And this is when our lead safe approach comes in and hopefully becomes the solution, not just in Cleveland, but in a lot of places. So if the first thing I left you with is prevention, the second that I really want to hone in on is this idea of a lead safe approach. So lead safe is very important. It's so important. We put it right in the title of our coalition, the Lead Safe Cleveland Coalition. And what the lead safe approach is the idea of making homes lead safe as opposed to lead free. We learned of this model, this lead safe approach, through the city of Rochester, New York, and they've had phenomenal success using it. They've actually decreased childhood lead poisoning by 85% over the course of 10 years. And what's really important to understand is lead free and lead safe are not interchangeable terms. The idea of lead free is if you were to abate a property. And if you abate a property, that means you're removing all of the lead-based paint from the home. Lead safe, however, is different. It means that you're not necessarily removing all the lead-based paint and the lead, sort of lead contamination of a home, but what you're doing is you're addressing all of the risks. So through a method called interim controls, you can actually create a lead safe home by doing things that are sometimes very low level in intervention. That includes maybe painting a surface, a window or a door frame. It also includes specialized cleaning. If you have a well-maintained property, achieving lead safe status should be relatively easy. Now, what I'll say here is it's not to say that abatement or lead free isn't necessary and important. That's a very important tool in the toolkit, but we know that that's expensive. In Cleveland, for instance, lead abatement sometimes looks like $20,000, $30,000 plus for each home. Lead safe, on the other hand, we've estimated out is about $3,500 per home. So it's incredibly cost effective. And as we've learned from a place like Rochester, it's still very effective at protecting children. It's based on this lead safe approach that the Lead Safe Cleveland Coalition worked with the city of Cleveland to pass some pretty transformational legislation back in 2019. That's the Cleveland Lead Poisoning Prevention Law. The lead poisoning prevention law is really the cornerstone of our work. And what it essentially does is it requires any property owner, rental property owner in the city of Cleveland who has a residential rental unit built before 1978 to proactively achieve a lead safe certification. And what that lead safe certification is a mandate that you get your home inspected and you make sure it doesn't have any lead hazards, and you receive either a risk assessment or a clearance examination proving that it has no lead hazards. What's important to note here is we actually do not have the lead safe certification run by the city of Cleveland. It's actually a property owner's responsibility to go out on the private market, find a lead safe inspector and our contractor if they need to do some remediation work, have them look at the unit, fix it up if necessary. So they're able to get that past clearance examination or risk assessment. Then they turn that into the city of Cleveland. and receive their lead safe certification. That law was passed back in 2019. We gave ourselves a nice hearty ramp up period, and it actually began to be fully implemented in March of this year. So just a few months ago. A couple really innovative pieces of implementation around the law that I'd like to highlight here. And also, by extension, show you a map of Cleveland as a little bit of a geography refresher, I suppose. Our law actually rolls out by zip code over the course of 2 years. We did that for 2 reasons. One, the certification is temporary. Lead safety is not permanent. If you're just painting over surfaces and cleaning, that's something that you're going to need to engage in on a cyclical basis. So the lead safe certification requires a landlord to do that every 2 years. The other reason that we roll out this way is because we don't want to overwhelm the private market, the lead safe workers who need to do the work to do it at any certain interval. And the same with administration on the city level. You want to make sure that our city is actually able to take in, certify those risk assessments, and clearance examinations they're receiving in a timely basis and not being overwhelmed. So it's this point in the presentation where I usually get a lot of questions on how we actually are able to help landlords meet this obligation. I am here on behalf of a housing organization, and something that we needed to be sure of before we even engaged in the idea of a lead safe certification is that we're actually pairing that mandate with resources for property owners. We are in a particularly low dollar housing market here in Cleveland, and I'm sure that's the case in many other places across the country. And so the idea that we would potentially burden property owners with inspection costs or remediation costs really could paralyze our housing market, and worse, could create displacement or a lack of affordable, decent housing if these property owners aren't able to stay in business. So the other key tenet of the coalition's work is that we have to have a carrot and stick approach, as we call it, and we need to pair the certification with resources. We really can't emphasize this enough, and I would be happy to answer more questions on how we arrived at that philosophy. But I will say a bit more here about the resources that we're trying to provide as a coalition. We created this concept called the Lead Safe Home Fund. And the Lead Safe Home Fund is the conceptual home, I guess you could say, for all of the resources we think would be necessary for a property owner to comply with the lead safe certification. So a bit more on the Lead Safe Home Fund. As far as we can tell, it's the very first of its kind in the nation. We don't know of any other fund of this type that is specifically created to assist with lead remediation. Like I said, it's the conceptual umbrella, and within it, there are a number of services and programs that I'll get into in a moment. But before I do, I just want to really underscore that this is not a public fund. This is a fund run by the Lead Safe Cleveland Coalition. It is facilitated by us, and that's really important because it's been able to garner significant public and private sector investment because it's sort of a neutral, independently run fund. And the other thing that we're able to do, because it is, again, not run by government, we are a little bit more flexible than perhaps some of their traditional lead remediation programs that may have certain income parameters or eligibility criteria to consider. The Lead Safe Home Fund, in our estimation, is going to be enough over a 5-year period to remediate all the homes in the city of Cleveland that need to achieve that lead safe certification. We've projected out a $99.4 million budget over 5 years. And that number is based on some pretty rigorous research, our understanding of the rental universe and the needs of landlords, our understanding of lead safe practices, and our knowledge and experience with some home repair products in the past. So I'll just quickly review the 2 key pillars of the Lead Safe Home Fund. One side is the Lead Safe Resource Center. The other is what we call Lead Safe Home Loans and Grants. So again, I'll do this quickly and happy to answer more questions. The Lead Safe Resource Center is brand new. It has now been created and it's launched. It's a physical location here in the city of Cleveland. And we've built it as the one-stop shop for all things lead poisoning prevention. It would help you as a landlord navigate that new certification requirement, but it also does a considerable amount of community outreach, organizing, and education. We understand that a big part of the battle here is getting folks educated on what lead poisoning is and how you can prevent your child and your family from being exposed to it. The other thing that the Resource Center does, and this is really critical, is it trains that workforce that's necessary to do the inspection and the remediation work for the lead safe certification. Like I said, that certification is not inspected by, or the remediation is not done by the city of Cleveland. That's all done on the private market. So our Resource Center makes sure that we are training enough workers to meet the demand out in the community. The other half of the Lead Safe Home Fund, and it's actually the bulk of that $99.4 million, I think it's $80 million in fact, is home loans and grants. And our loans and grants are three essentially products. We've created a new loan product specifically tailored to do these interim controls, lead remediation, lead safe work in homes. We've created a grant product that does the same, but it's available to lower income property owners. And finally, we've created a incentive product, and it's exactly what it sounds like. It's an incentive to get landlords into this new way of doing things, which is the lead safe certification. We're well aware that the lead safe certification is real systems change work. We are changing the way we interact with landlords and the expectations we have of them. So we need to make sure we're incentivizing them to participate in this new system, not just mandating them into participation. So a hallmark of the Lead Safe Home Fund, like I mentioned, is that it's a public-private fund. We're really incredibly proud of that fact. We have worked with entities really across the scale to garner investment into the fund. Like I said, it's a $99.4 million fund. And to date, we've actually fundraised $45.9 million of that, which I'm incredibly proud to say. And we've done that honestly in less than 2 years. And I think part of what makes it so attractive is that it's really acknowledging the fact that we all have a role to play in preventing lead poisoning. We often like to say at the coalition that lead poisoning affects everybody. Remember those long-term consequences. So that means since it's affecting everybody, we all have a role to play in addressing it. So to date, we're really proud to share some of the fundraising success we've had. We actually have investment, soon to have investment from every single level of government, including the federal government in the Lead Safe Home Fund. And what's really remarkable here is that this is bipartisan support. We're not just getting investments from the city of Cleveland into the fund, but we actually have substantial investment from the state of Ohio. We've been included in 2 of the last state budgets, a direct allocation into the Lead Safe Home Fund. And we're currently working with Congress on an earmark into the Lead Safe Home Fund. So this really is a bipartisan effort. And I think in part, our public sector partners have been so encouraged because we have also pulled in significant and new types of investment from philanthropy. We don't just have grants from philanthropy in the Lead Safe Home Fund. We actually have PRIs, program-related investments that serve as loans in the loan fund portion of our fund. We're doing that with a number of foundations who have never done PRI work. So again, really testing the waters and creating a new way of doing business. And the same is true on the private sector side. We have some traditional involvement from banks, community development, finance institutions, CDFIs, but we also really interestingly have some investments from our major hospital systems, including the Cleveland Clinic and Medicaid managed care companies. CareSource, it's actually the largest MCO here in Ohio. They've made a significant investment into our loan fund. So I really can't say enough for how transformational this loan fund has been to our work, but really the amount of times that we've been asked to share this model with folks. We already know of it being replicated in Detroit, Buffalo, and Toledo, and we're also in talks with some other folks, including pretty far advanced in Milwaukee. So we're really, really proud of the Lead Safe Home Fund. And again, this idea of pairing the Lead Safe certification mandate with resources for landlords to use. So the last two quick things I'll say here, because I know I've been going on, is this work is not possible with a couple of other really important cross-cutting pieces. One is the idea of public awareness. I shared with you here a few of our marketing collateral pieces. Again, if people don't understand lead poisoning, they're not hearing it from voices that they know and trust, they could be reticent to get involved in this system. So you'll see storytellers. These are real people from the city of Cleveland, real landlords, real community resident leaders, helping to share the message of lead poisoning prevention and the lead safe certification mandate. And then finally, we really value research and valuation at the Lead Safe Cleveland Coalition. We have 3 levels of evaluation. We have an auditor in place. We have a public dashboard, which I have a photo of here. And then we do monthly, quarterly reports to the public. So just wanted to highlight that because we really believe we can only be successful if we're tracking our progress and measuring it against the rates of childhood lead poisoning and seeing if we're having a real impact in bringing those down. So that brings me to the end here. I just want to, again, underscore the 4 things I really wanted to highlight. These are, it's not a silver bullet, but there are 4 things that we would recommend to any community, city, county, state, considering this work. 1 is that there's incredible value in a coalition of public-private approach. 2, prevention, prevention, prevention. If you can get upstream before a child's poisoned, you can avoid so many long-term consequences. 3, we would really consider a lead safe approach in addition to a lead free. How can you do abatement and remediation? Just as effective at protecting children, but can be far more cost effective for property owners. And then finally, for any effective system change, right? Probably not just lead poisoning prevention. How can you consider pairing mandates, whether it's a lead safe certification or other types of code enforcement, with resources for property owners? So with that, thanks again for having me. I'd be really happy to answer any questions.
Thank you. That was a powerful presentation. That's quite inspirational. I think that Cleveland has taken this on and done this in the manner in which you have. So thank you for that. Professor Gamble.
Thank you. I enjoyed your presentation. I have a few questions, and I appreciate you sharing the dollar amount and the goal for the program. And that's impressive that you've raised that much private funding. Is there an average cost per dwelling that you could kind of cite for what this looks like for the individual residents?
Yeah, absolutely. And that's a question we often get because it really is the core of the lead safe approach, this idea that we can make it more cost effective for a property owner. I think I mentioned what our average abatement costs look like, which is a lead-free approach. That can often be $20,000 to $30,000 or more for a home. Our lead-safe approach, which again is more cost-effective, a lower level intervention, we've modeled it at $3,500 per home. And now that can go up if you need a little bit more work in your home to create lead-safe conditions. And it can also go down if you have a really well-maintained property that doesn't need a lot of work. Perhaps you just need a specialized cleaning. But on average, for our Cleveland housing stock, we've estimated $3,500 per home, per unit.
Thank you. And as far as the workforce goes, you were talking about trying to, make sure you have individuals available to perform the service. Are you struggling there? I mean, we're seeing the challenge all over the country just to, find folks to do things. So how are you approaching that? How are you recruiting? And can you share a little bit about that?
I would sum it up by saying so far so good in terms of our workforce development. We've really modeled out a few different lead safe worker types that we know are going to be necessary. I'll just list a few here. There's a clearance examiner who does clearance exams, risk assessors who can come in on the front end and the back end. On the front end, they would outline the work that needs to be done in a home to make it lead safe. And on the back end, they could test it and make sure that it is in fact lead safe. We're training a number of lead abatement contractors. Now, don't let the term abatement scare you off there. While they can do lead abatement work, they can also do lead remediation work. So those are the three core lead safe worker positions that we're actually actively training for. Our Lead Safe Home Fund provides free trainings for all three of those positions. And we actually encourage not just community members to come and access a potential career pipeline through this work, but we also encourage landlords, property owners to come through some of these sessions to become kind of DIY landlords. They can't inspect their own property, but they can certainly do their own lead remediation work if they're certified and qualified. So with us targeting those two audiences, community residents hardest hit by lead poisoning and property owners themselves who want to pursue DIY, we haven't seen a workforce crunch yet. Now we are early in the lead safe certification as the mandate continues to roll out, and honestly enforcement maybe gets a little bit more strict through the city of Cleveland. We could maybe see that demand on workers spike up. So we're carefully watching it, carefully making sure we have enough lead safe workers to fill the need, but also not flooding the market. But so far so good.
All right, and then last question, as far as replication goes, if a city wanted to do this, do you have any type of agreement where they can, basically use what you've developed, or is there any type of charge or licensure or anything that they'd have to do?
No charge. We are happy to help. We've actually talked with a number of communities and states about how they could replicate it or adapt the model in some instances. And I'll just say too, from the perspective of enterprise community partners, we stepped into this work in Cleveland, but we exist in a lot of other communities across the country, including in Georgia. And this is really our bread and butter work. How can we bring people together for systemic problems that need systemic solutions?
Thank you.
Thank you. Are there any other questions or comments here or online? Not seeing any, we'll say thank you for that wonderful and very informative presentation. You've given us a lot to think about, and congratulations on all the work you have and are committed to do. Appreciate that. And I know there are families and lives that don't even know how much they will appreciate it.
Well, thank you so much. I appreciate the opportunity to be here and again, commend the work of the study committee.
Thank you. Okay. Next up, we do have, I think, one person on Zoom perhaps that wants to give public comment. So we'll open up the public comment time. And I think first we have Mr. Lopez, if you are able to join us.
Good afternoon, everyone. Can you hear me? Can you see me?
We can hear you. You may need to bring your camera down just a little bit for us to be able to see you. There you go. Thank you. Thank you.
Okay. Madam Chair and distinguished members of the committee. For the record, my name is Prince Joseph Roland Albert, and my last name is Lopez. I am the founder, chair, and CEO of the Rochelle Marketplace Downtown Development Authority. I reside in Rochelle, Georgia, zip code 79. Contact information has been sent in for the record. Environmental pollution from former, present, and perhaps future industrial sites in the heart of our community, and a very old housing stock that is 102 plus years old, are now in bad condition, preyed on the systemic poverty of the residents of Rochelle, Georgia, City District 1. Our children greatly suffer from misguided diagnosis, which doesn't zero on lead poisoning. Policy recommendations. As I don't want to go, I heard a wonderful presentation. I don't think I need to add anymore. But some of the policy recommendations that I would like to put onto the record will be that children are to be tested for lead poisoning at the beginning of each school year, starting at Head Start and beyond. Funds to be allocated to help parents bear the financial burden of testing at 60% of AMA, that's area medium income. Make residential lead testing and abatement grants available to communities under the same guidelines at 60% of AMI. Make provisions for cities that have no code enforcement. Rochelle and so many other towns in Wilcox County don't have a code enforcement department. I will enter the extended written remarks into the record, and I am available for questions if you should have any. And with that, I thank you so very much for your attention.
Well, thank you. And thank you for listening and following the work that we are considering here. I appreciate that. And for your comments and advice for us. Are there any questions or comments from the members here or joining us online? Not seeing.
Madam Chair,
Thank you so much.
thank you so much.
Yes, and that was the only person that we had signed up at this time for public comment. But I will tell you that anyone who might be following this or even reading later online, we can post a email address for Tara Buchholz so that if you do have some comments you'd like to make as we begin to pull this together, that you could send them to us. If you will just check the House site under this study committee, you should be able to access that. And if you can't, you can certainly call my office or Tara's office as well to get that. I want to thank everyone that's been a part of this. Now, we're at the point right now where it looks like we're going to be pulling together all of these facts and then consider what we might put forward as suggestions as the findings from the study committee for consideration to maybe really impact this lead poisoning conversation that we've all had. There will be a fifth meeting. It's not scheduled at this point. I hope that we can do it as we come into the special session coming up. If not, we'll do it shortly after that so that the report can be presented in the timely manner as required by the resolution. I want each of the members of the committee, I want to thank you all, first of all. I know this has been a time commitment to be here or to listen in or to follow and check on it later, however you may be able best to do it. But this has been really so important. In our last presenter, it really went straight to the heart of this, that no child should ever be poisoned by lead. And I think that needs to be Georgia's goal now as we move forward. What can we do? How can we do it? It is a steep hill, but certainly not an impossible one to climb, I think. So I want to thank all of you. I want to say that if any of the members have any information they would like to put forward to, please do send that to Tara or to my office, and we will be in touch about the next time we convene. If there's anything else that you think we have not discussed that we should, anything that's been left out of this too, if you'd let us know right away with that, that would be very important. And to all of our presenters, if you have any more information, y'all have certainly given us a lot and answered so many questions, even told us things I think we didn't know we needed to know. So I thank you for that. And if there is no further business, we are adjourned. Thank you.